The STOP DAPT-3 trial, evaluating short and optimal duration of dual antiplatelet therapy after a drug-eluting stent. Dual antiplatelet therapy with a P2Y12 inhibitor on top of aspirin is the established treatment to prevent ischemic cardiovascular events, stent thrombosis in particular, at least 1 month after coronary stent implantation, as shown in the STARS trial. However, the role of aspirin as a component of DAPT has not been established in clinical trials. The incidence of major bleeding events within the 1 month mandatory DAPT period after PCI remains high in clinical practice, particularly in patients who had an acute coronary syndrome or high-risk bleeding. Short durations of DAPT followed by a P2Y12 inhibitor monotherapy demonstrated 40% relative risk reduction in bleeding events without increasing cardiovascular events compared to standard durations of DAPT after PCI using new generation stents. So removing aspirin from the DAPT regimen in high bleeding risk patients early after PCI could reduce major bleeding events without compromising cardiovascular events. This was a multi-center, randomized, open-label trial comparing aspirin-free versus DAPT strategy in patients with ACS or high bleeding risk, undergoing PCI with everolimus-eluting stents. 6,000 patients were randomized after coronary angiography. Prasugrel 20 mg was loaded before PCI in both groups. In the non-aspirin group, prasugrel 3.75 mg per day was continued up to 1 month. In the DAPT group, aspirin was loaded before PCI if aspirin naive. Aspirin and prasugrel was continued for 1 month. Primary analysis was conducted 1 month after randomization. Here are the baseline characteristics. The average age was 71 years, 76% were men, 75% of patients had an acute coronary syndrome, 42% were STEMI, 19% with NSTEMI, 14% unstable angina. About 19% had heart failure and 55% of the patients were at high bleeding risk. Almost 80% of the patients had a radial approach, with an average of 1.4 stents used. About 20% of patients had multi-vessel PCI, and most used IVUS or OCT. Antiplatelet agents were used in 34% of patients within 7 days before assignment in both groups. Heparin was used in about 24% of patients before PCI in both groups. The incidence of major bleeding in the no aspirin group was 4.47% and 4.71% in the DAPT group. Hazard ratio was 0.05 with a p-value of 0.66. So the no aspirin group was not superior to the DAPT group in terms of the co-primary bleeding endpoint. Regarding the co-primary cardiovascular endpoint, the incidence was 4.12% in the no aspirin group and 3.69% in the DAPT group. P-value for non-inferiority was 0.01 with a hazard ratio of 1.11. So the no aspirin group was non-inferior to the DAPT group in terms of a co-primary cardiovascular endpoint. However, the key incidence of definite or probable stent thrombosis was numerically higher in the no aspirin group compared to the DAPT group, especially in subacute stent thrombosis, seen on the right. The other endpoints at 1 month were similar. However, the rate of any unplanned coronary revascularization was higher in the no aspirin group. So in conclusion, the aspirin-free strategy using low-dose prasugrel compared with the DAPT strategy failed to attest superiority for major bleeding within 1 month after PCI and was associated with a signal suggesting an excess of coronary events. So DAPT with aspirin and a P2Y12 inhibitor will still remain the standard strategy for at least 1 month after PCI.